Hello, welcome back. Today we'll be starting with the pelvis and a little bit of the thoracic cavity. Okay, so the posterior abdominal wall is bordered by the 12th rib up top and the diaphragm. Inferiorly, it's bordered by the iliac crest, and then laterally, there's a vertical line from the end of the 12th rib down to the iliac crest. And that's composed of the abdominal muscles. Okay, so the layers, first we start with the skin, and then there's going to be the subcutaneous fascia, also known as the Campa fascia, and it is continuous with the body and that of the gluteal body, so this will extend like from here all the way into the gluteus. And then deep to that is going to be the scarpa fascia, which is made out of the subcutaneous tissue. And then there's going to be the investing fascia. There's going to be the superficial, intermediate, and the deep. And the muscles are going to be external oblique, internal, and then the transversus. And the deep fascia are all called the thoracolumbolus fascia. It's a broad aponeurosis. And then deep to that is going to be the extraperitoneal fat. And then the endoabdominal or the transversalis fascia. And then lastly is going to be the parietal peritoneum. And then there's going to be the petit triangle or the lumbar triangle. It's bounded by the external oblique, the latissimus dorsi, and the iliac crest. And then the floor is going to be the internal oblique. This particular triangle is important because this is a site where herniations can occur. Okay, so the second layer in is going to be composed of the intermediate back muscles, so the serratus posterior, inferior, the erecta spinae, and obliquus, and abdominis internus, and then those are kind of like forms the Levator triangle, and it's also known as the superior lumbar triangle, and is bounded posteriorly by the Quadratus lumborum, superiorly by the 12th rib, and then anteriorly, is the internal oblique. And then the roof of the triangle is going to be the external oblique. Here it's cut, you see here. And here is also the latissimus dorsi, so that will also cover this triangle. This triangle is also a notable triangle because hernias can also occur through this triangle. And it contains the subcostal vessels and the nerve. Here is another visual of where the triangles are. Here is the petit triangle, small, and here is the superior lumbar triangle. It's more in this region right here. And just to repeat, here's the boundaries, the 12th ribs, the paraspinal muscles, and interior oblique. And then over that would be the lat and the external obliques. Okay, so deep to that is the third layer of muscles, and it is bounded by the Quadratus lumborum, the psoas major and minor, and the transverse abdominis. So that would be like wrapping around all of this, right? And all of this will be covered with the endoabdominal fascia. And the superior border of this is the diaphragm. Okay, so let's go through the individual muscles. The Quadratus lumborum, the origin is the medial half of the inferior border of the 12th rib, like right here, closer to the spine, and the tips of the lumbar transverse processes and then it inserts into the iliolumbar ligament and the internal lip of the iliac crest. So this is a posterior view right here. So there it is, into the crest of the ilium. And the action is to fix or depress the 12th rib during respiration and to laterally flex the vertebral column to the same side. So it helps with, like, bending from side to side. It's innervated, by the lumbar plexus. Okay, so the psoas major and minor, the origins are essentially the same. The transverse processes of the lumbar region and the intervertebral discs of T12 to L5, and it inserts into the lesser trochanter of the femur. The upper part of the psoas major will be enclosed in the medial arcuate ligament, and then the minor will have the same origin and sometimes the same insertion. Other times it can be inserted into the ischium. And then this is not really a notable muscle because a good percentage of the population does not have it. It works as both the psoas major and minor work as a weak flexor. And these are more like supplemental muscles. It just helps the more important muscles in the flexion of the trunk or flexion of the hip. It's innervated by the L1 anterior ramus. Okay, so the iliacus, their origin is the upper lip of the iliac fossa, and then it fans down, and then all the fibers merge into the tendon, which inserts into the lesser trochanter of the femur. This is the main muscle of flexion, where it flexes the thigh at the hip, so bringing the thigh up, or it flexes the trunk of the thigh fixed, so helping you bend over. It's innervated by the femoral nerve. The endoabdominal fascia, it protects the internal organ by having that layer of fatty tissue, and that of course will absorb any kind of shock or trauma. It also works in thermal regulation. The abdominal blood and lymph vessels lie within the fascia, and the principal nerves will lie outside. And of course there's the two types. There's going to be the camper and the scarpa's fascia. Okay, part 2, the bony pelvis. The bony pelvis, the main function is to transmit the weight from the upper body to the femurs. And it contains, support, and protects the pelvic viscera and provides the attachment for the trunk and lower limb muscles. And it's important to know that the bony pelvis is not just one big bone, right? There's actually 4 separate bones. It's composed of 2 ilium, so this would be the fossa of the ilium, here would be the crest, but this is the ilium, and that is continuous with the ischium, which is the sit bones. And then there are 2, and then those are connected to the sacrum, and then that is attached to the coccyx. And this all make up the bony pelvis. The joints are the important ones are the pubic symphysis, which is, as we talked before in the lecture about joints. It's a secondary joint, so the edges are going to be aligned by hyaline, and then in the middle would be a fibrocartilaginous pad. The other thing that to note that is reinforced by the anterior, posterior, superior, and inferior pubic ligaments. Oops, sorry, this is sensitive today. So this is a very strong attachment. It takes quite a bit of trauma in order for this to be displaced. And the other joints are the anterior, posterior, interosseous, and sacroiliac ligaments. Sacroiliac would be right here, and the joints are all like covered by those ligaments. Other notable ligaments are the sacrotuberous and the sacrospinous. Here's the posterior sacroiliac ligament right here. These are the iliolumbar, connecting the ilium to the lumbar vertebra. This is the interosseous sacroiliac ligaments. Here's the dorsal sacroiliac ligament, and then there's going to be the deep dorsal ligaments, and then here's the arcuate pubic ligament. So this would be the posterior interosseous sacroiliac ligament, and the iliofemoral ligament is the strongest ligament in the body, but the posterior sacroiliac ligament is the next strongest in the body. And during pregnancy, hormones will be released and make the ligaments hydrophilic, so they are able to absorb water and stretch during pregnancy or during childbirth, really. So, okay, here's the pubic symphysis, here's the sacroiliac joints, and here are the posterior sacroiliac ligament, and here's the sacrospinous ligament, and then we will go through that to the sacrotuberous ligaments right here, because these form some pretty important foramina. Okay, so the sacroiliac joints, there's only 2 of them. And the sacral surface of the joints is covered by hyaline cartilage, and the iliac surface is covered with fibrocartilage. And the anterior sacroiliac ligaments, there's a thickening of the anterior surface of the articulate capsule, and the posterior sacroiliac ligaments are kind of divided into the short intrinsic and then the long extrinsic ligaments. The iliolumbar, so as you can guess, it would be like right here, attaching into the lumbar spine. Ligaments will pass the tip of the transverse process of the 5th lumbar vertebra to the posterior part of the inner lip of the iliac crest. So that just means it connects from there to there. It's a rather short but strong ligament. Okay, so the sacrotuberous and sacrospinous ligaments, they form these 2 holes, right? The sacrotuberous ligament is from the lateral part of the sacrum and coccyx, and then it inserts into the posterior iliac spine, along with the the origin is from the sacrum, the iliac spine, and the coccyx, and then it inserts in the posterior. It inserts in the ischial tuberosity right here, down here, and then the sacrospinous ligament is attached to the base by the lateral part of the sacrum and coccyx, and then the apex would be the spine of the ischium. And by doing that, it creates the greater sciatic foramina and the lesser sciatic foramina. And it converts these notches, like the entire opening is called a notch, but like making it, the ligaments will close it off, making it foramina. It's just the way anatomists like to just define how large structures are in the body. Okay, so the obturator membrane is the membrane that almost closes the obturator foramen, and in doing that, it makes this little canal called the obturator canal, and that will transmit the obturator nerve and vessels. So the pelvis is split into 2 parts, the true and the false pelvis. The false pelvis is essentially just this like ring and above it. So it's really bounded by the iliac fossa. As you can see here, like this is like the main, it's like a shallow main bowl of the pelvis. and while the true pelvis has the inlet and outlet and the cavity. And so it would be like here would be the inlet, and then down here would be the outlet. But this would be the true pelvis below this lip, right? So the pelvic outlet would be bound by the coccyx, and then all those ligaments, the ischial tuberosity down here, and the pubic arch. The pelvic cavity lie between the inlet and the outlet, of course, and the inlet, or yes, the inlet would have like a shallow anterior wall, and then there's going to be a deeper posterior wall. The anterior wall here, deeper right there. It's important to note the differences between the male and the female pelvises. Males have heavier and thicker bones in general. It's just the way humans have developed. This is not true of every single human. There's, of course, some differences due to lifestyle. But in general, males do have more musculature than women, and that's why and their bones are going to be heavier and thicker. The joint surfaces are going to be larger because of the increased amount of, like, not really the amount of fibers per se, but the tendons will be larger, so the area of attachment will be larger than females. Why? Just males are able to bulk up and build muscles just far more than females. And the muscle attachments, like I said, are going to be well marked because the muscles will be pulled during contraction. Males will, well, sometimes females too, if they work out quite a bit, right? But the more the repetitive contractions with heavy weights, working out, the more hypertrophy there would be, and the muscle attachments will be stronger due to the increased pull, so there would be increased roughening of the bone. In males, the false pelvis will be deep, while the false pelvis in women will be shallow. Why? To carry children. The pelvic inlet of the males is going to be heart-shaped, while the females is going to be oval. Why? To help with the birth of the child. It would be easier to come out of a wider inlet. The pelvic canal is going to be long and tapered, while the canal is going to be short with almost parallel sides. The outlet is small in males, while in females it's large, of course. And the obturator foramen is going to be round, while the obturator foramen is oval in females. This is a little bit less important, but it's important to know these general features. Okay, these pelvic measurements are very important, so you do need to know these numbers. So the diameter recta is going to be from here to here. It's generally 11 centimeters, give or take a couple, but the average is 11 centimeters. And then the diameter transversa is going to be 13 centimeters. And the diameter obliqua is going to be 12 to 12.5 centimeters. And then the outlet, and the diameter recta normally is only 9.5 centimeters, but it can increase to 11 centimeters during childbirth. And then the diameter transversa is going to be 11 centimeters, so making it almost circular and round. The conjugata diagonalis is going to be around 12 to 13 centimeters, and this distance is going to be 1.5 centimeters in the critical or the true conjugate. And then the conjugata externa is going to be about 20 to 21 centimeters. The axis of the pelvis will join the central points of the antero-posterior diameter from the inlet to the outlet. There you go. You can measure the conjugata diagonalis by placing the fingers, as you can see, in the vagina and kind of like measuring how long your fingers are in relation. This is not really common anymore. This is a little bit dangerous to do because as the females are giving birth or like still preparing for birth, this can interfere with things, and it can be very uncomfortable for the patients. And in general, this is just not really a common practice anymore. This is much more common. The true conjugate is about 10.5 centimeters, but like I said, not many people really measure it anymore. But we can estimate it from all the other values. It's important to know these values because it gives an idea how the birth will happen. It will kind of give you an idea that if the pelvic outlet is going to be too narrow, the child must be removed via cesarean section. Okay, so these are the different types of the female pelvis. The gynecoid is the typical female pelvis with a shallow false pelvis and a nice, almost roundish outlet. And then the android is going to be much more similar to a male. The outlet is going to be heart-shaped and rather contracted. This is problematic because it's much more difficult to give birth with this kind of pelvis. The anthropoid is going to be a long, narrow, oval-shaped pelvis, and this is actually pretty common. It's important to keep track because if the pubis symphysis will not stretch enough for it to be like round, it might give some birth complications. The platypeloid is the rarest of the pelvises. And this only occurs in like 2% of the population, but it's going to be wide. The fossa itself will be kind of flattened, and then the promontory of the sacrum, like this, will be pushed forward, so it's going to be like more prominent, of course. This is problematic for childbirth because with the strain and the pushing, the sacrum might actually be fractured. Okay, so let's go through the muscles of the pelvis. There's going to be the parietal muscles, which are the Obturator, Obturatus internus. As you can see here, comes from the greater trochanter and in, along with the Piriformis muscles. The visceral muscles will form the pelvic diaphragm, and that's going to be the Levator ani, the puborectalis, the pubococcygeus, and the iliococcygeus muscle. Iliococcygeus right here, and then like deep to that would be the pubococcygeus, and then up most superior would be the coccygeus. The coccygeus, and then the sphincter ani, externus or external anal sphincter, be right here. Right here. This is the bulbospongiosus for males. And here's the difference between the male perineal muscles and the female perineal muscles. So this will be this structure right here will be the testes would be kind of like going through this, right? Well, here this would just be the bulbocavernosus. Okay, so the Obterator internus is a small muscle right here, and the origin is the Obturator membrane and the hip, and then it inserts into the greater trochanter, crossing over. This will laterally rotate the femur, and it's innervated by the sacral plexus. The Piriformis The origin is the sacrum. It also inserts onto the greater trochanter and also laterally rotate the femur. This will be innervated by the sacral plexus. And this is important muscle because there's something called a piriformis syndrome. That's where the sciatic nerve is compressed when the piriformis is like inflamed. So if you've done any kind of exercise and you strained it and it is inflamed, it will compress the sciatic nerve, causing all of like the sciatic nerve symptoms. So the levator ani, the origin is the back of the pubis, and it will work with supporting and raising the pelvic visceral structure, so it helps with sexual functioning, defecation, and urination. And it's made out of these muscles: the puborectoralis, the pubococcygeus, and the Iliacus muscle. As you can see here, they're all from like this similar origin. Here's the rectal hiatus for women. This is going to be the vaginal canal. For men, there would be like the spermatic cord would go through it. Here's the urethral hiatus. And of all the muscles, they all work in a role of maintaining maintaining tone and keeping all of the organs inside. But the iliococcygeus is the only muscle that is the true levator. So whenever you you contract your internal muscles and you feel that kind of like contraction of all muscles, you really feel the iliococcygeus muscle contracting. All of these are innervated by the S4 anterior ramus along with the S2, S3, S4 roots. So the anterior fibers are the levator prostate or the sphincter vaginae, and that forms like a sling around either the prostate or the vagina, and it inserts into the perineal body. And the purpose is to stabilize the perineal body. The posterior fibers are the iliococcygeus, the anococcygeus, and the iliococcygeus, and that will insert into the anococcygeal body and the coccyx. There you go. You don't see it as well in males, but it is there as well. The intermediate fibers are the puborectoralis and it's the puborectalis, and it will form the sling around the junction of the rectum and the anal canal, and it will maintain the fecal continence, and during defecation this muscle relaxes. The pubococcygeus passes posteriorly and it inserts into the anococcygeal body. Okay, so the muscles work to resist the rise in intrapelvic pressure during straining and expulsive effort of abdominal muscles, such as sneezing, coughing, vomiting. It also serves as the sphincter of the vagina. And then what is important is that the perineal nerve will innervate the external genitalia of both the sexes and the skin around the anus, the anal canal, and the perineum. And it goes through this canal, also known as the pudendal canal, and anatomically it's known as Alcock's canal. And then there are the motor nerves that will innervate the pelvic muscles, the external urethral sphincter, and the external anal sphincter. So if you remember the little mnemonic to remember the cervical branches or cervical nerves, so remember C345 keeps you alive. Those cranial nerves, or I'm sorry, not cranial nerves, those cervical nerves are involved in respiration and the heart. There is something similar in the sacrum. So it's S234 keeps the poo off the floor. So remember, 2, 3, 4 nerves will innervate the entire pelvic floor, and the purpose of the pelvic muscles is to stay contracted and to keep the poo off the floor. The coccygeal muscle is originating from the ischial spine, and it inserts into the sacrum and the coccyx. And it works in conjunction with the levator ani in supporting the pelvic viscera. These are going to be innervated by the branches of the 4th and 5th sacral nerves. The sphincter ani externus is going to have the subcutaneous and the deep parts that encircle the anal canal, and those don't have any bony attachments. And the superficial part does, and it originates from the perineal body, and it inserts into the coccyx. These muscles work with the puborectalis muscle to form the voluntary sphincter of the anal canal. So this is going to be the somatic part that we can control, and the inferior rectal nerve and the perineal branch of the 4th sacral nerve is innervating it. Okay, so injuries. Most commonly, the injuries of the pelvic floor would be through childbirth, and it causes like rectal or uterine or vaginal prolapse, and that means that all these organs kind of go through the rectum. And in rare cases, there could be even the herniation of the bladder. The alteration in the position of the bladder neck and the urethra can lead to stress incontinence, which means you're not able to control urination very well or anymore. When it's like people who have given birth to multiple children and are elderly, that's why they have like problems like controlling their bladder when they laugh very hard, or when they sneeze, or when they cough. Okay, so the parietal pelvic fascia cover the sphincter urethra and the perineal membrane. They form the superior fascial layer of the urogenital diaphragm. The visceral layer will surround the pelvic organs as adventitia, and in certain places the fascia thickens and extends from the viscus to the pelvic wall. Well, what's important to know, these are just protective fascia to keep the structures in place and not allow things to move along, especially during things such as straining. Okay, let's go through the fractures. So avulsions are most common in young athletes due to the strain of the muscle, and the metaphysis isn't quite mature yet, so the contraction of the muscle is going to be stronger than the bone itself. The fracture of the bone is much more common than disruption of the ligaments, because, like I said, the ligaments are very, very strong. And generally, the fractures occur because of anterior posterior compression or lateral compression and shearing forces due to falls or car accidents. The complications with these fractures are very dangerous because the internal iliac artery may be affected, and damage to that can lead to massive hemorrhaging. Other dangers would be bladder perforation, and that could lead to septic shock because the bladder contains urine, which is toxic to the blood, and rectal tears can occur. Rectal tears can be dangerous if it is bad enough. Of course, there's a lot of nerve damage that can happen. The sciatic nerve runs through it, the obturator nerve runs through it. It's all innervated by the sacral and the lumbar plexus. And for males, the urethra and the penis is often damaged, especially in the vertical shear fractures. So these are the different types. Here are the anterior posterior compression. So type 1 is where the pubic symphysis is torn. Type 2, when it is torn and the posterior ligaments are torn and the pelvis is displaced. And then type 3 is the pubis symphysis is torn, the like sacral ischium ligaments are torn, and the sacroiliac ligaments are torn. This is the rarest because remember what I said, this is like the strongest ligaments of the body. Okay, so the compression, lateral compression, so the force would be coming like here through the side, follow the arrows. There would be a break of the neck of the ilium and the ischial bone. Here would be like the crest would be broken along with these bones, and this would be an inwards displacement. And type 3 would be the worst of them all, clearly, because it's also affecting this side. So here the iliac crest is going to be broken, the ischium is going to be broken, like the pubic symphysis is going to be disrupted, and then the sacroischium or sacrococcygeal or coccygeal ischial ligaments are going to be torn. Vertical shear forces, as you can see, just like shears everything on one side of the pelvis. So here it can also be kind of like, you know, diagonal. So the pubis symphysis is going to be torn, and then here the posterior iliosacral ligament is going to be damaged. There's three different types. Complete break, partially stable, like, you know, like fracture here, but this is mildly torn, and then complete unstable is when the entire half of the pelvis is going to be like avulsion. Okay, so thank you for your attention and good luck studying.